All right, we might make a start. So my name is Rhonda Garad, and it's my great pleasure to be your host for today's webinar. So welcome everybody to the first of 3 webinars on the Let's Talk About Menopause series, with today's focus on spontaneous early menopause. It's wonderful to see so many of you here. World Menopause Day was on October 18th, and the focus for 2020 was premature ovarian insufficiency, and this webinar is in support of that day and women with POI. I would like to begin by acknowledging the traditional custodians of the lands I am on today, the Bung Warren people of the Kulin Nation, and extend my respect to elders past and present and emerging. I acknowledge that we are all on Aboriginal land today, and I extend my respect to Aboriginal or Torres Strait Islander people who are joining this webinar today. I recognise that sovereignty was never ceded and that we are the beneficiaries of stolen land and dispossession, which began over 200 years ago and continues today. So today we're here to hear from the experts. The first expert we'll be hearing from is Clinical Associate Professor Amanda Vincent. Amanda is a clinical researcher with a focus on early menopause. She has worked as an endocrinologist at the Monash Menopause Clinic for more than 20 years and leads early menopause research at MICRI. We also have Associate Professor Jackie Boyle. Jackie's a gynaecologist who also works at the Menopause Clinic at Monash Health and at Jean Hales for Women's Health. Jackie's also Deputy Director of the Monash Centre for Research and Implementation at Monash University. We're also delighted to have Kirsty Costa. Kirsty is an educational professional who was diagnosed with premature ovarian insufficiency at age 31. She's here to share her experiences and insights into what it was like to be a young woman experiencing menopause before the age of 40. And last but not least, we have Kate Johnston-Ataata. Kate is a research fellow at the Social and Global Studies Centre at RMIT University. She's a health and family sociologist interested in fertility and reproductive health, and worked with Amanda and Jackie on the Early Menopause Experiences project. So once we have heard from the experts who will give a 5-minute presentation, we'll come back for the Q&A session. We've received a number of excellent questions from you at registration, so we'll be answering them today. But please also put any other questions you might have in the Q&A box, and if time permits, we will also get to them. Please also note, we can't give individual medical advice today, but there will be a link in the chat box as to where you can search for clinical advice near you. Also, this webinar is being recorded and will be made available in the coming weeks on the Women's Health Victoria website. Unfortunately, Di Hill, CEO of Women's Health Victoria, couldn't be here today, but she wanted to say how pleased she is that Women's Health Victoria is a partner in this government-funded digital health project with Monash University, RMIT, and our other partners. She wanted to say this is a very important project aimed at improving outcomes for women with early menopause, a challenging health issue for many women. Di also says it's a great pleasure to be assisting to host this webinar today so that women can find out more about early menopause from the experts and hear about the most up-to-date research, treatment and support available. So without further ado, I'm going to hand over to our first expert, Amanda Vincent.
Thank you, Rhonda. Next slide, please. So what is early menopause? At birth, there are approximately 1 million egg cells in the ovaries. However, there is a progressive decrease in these eggs throughout a woman's life, so that by the time she is aged 50 to 51 years, there are very few eggs remaining. And so her periods stop and menopause occurs at that time. However, some women are born with fewer eggs, or they lose eggs at a faster rate and so reach menopause at an earlier age. Thus, early menopause we define as menopause occurring before age 45 years and affects up to 12% of women. Premature menopause, or we prefer the term premature ovarian insufficiency or POI, is loss of ovarian function before the age of 40 years, and this affects up to 3.5% of women. The cause of early menopause or POI is unknown in most women. Genetic studies have linked certain individual genes involved in DNA repair, cell metabolism, hormones, or the immune response with the age of menopause. And it is thought that changes in these genes leads to an accelerated loss of the egg cells and their supporting cells in the ovary. The problem is that a lot of variation is seen between women and between the research studies. So at present, we cannot identify a specific genetic cause in most women. This is an area of ongoing research, so hopefully we will have answers in the future. However, there are certain genetic conditions that we can identify. The Fragile X premutation is associated with a 20% chance of POI and can be detected on a blood test. Chromosomal abnormalities, and the commonest one of that is Turner syndrome, which affects the X chromosome, are also associated with an increase of early menopause and can also be detected on a carrier-type blood test. There are autoimmune diseases, particularly adrenal or thyroid disease, which can be associated with early menopause, and viral infections such as HIV or mumps. Chemotherapy or radiotherapy is toxic to the ovaries, leading to accelerated loss of eggs and also damage to the ovaries. And obviously, surgical removal of both ovaries causes surgical early menopause. Early menopause has multiple impacts on a woman's life. The loss of egg cells results in infertility, and importantly, the ovaries also produce sex hormones, particularly estrogen. Estrogen deficiency leads to menopausal symptoms such as hot flushes and vaginal dryness. Early menopause is also associated with psychological distress, decreased self-esteem, anxiety, and depression. Early menopause is associated with an increased risk of heart disease and also osteoporosis or bone fragility with an increased risk of fractures. Estrogen has beneficial effects on bone, blood vessels, and anti-inflammatory effects, and these beneficial effects are lost following early menopause or POI. There are some, but not all, studies which suggest there may be an increased risk of cognitive problems and dementia, but there does seem to be a decreased risk of breast cancer. The effects may be worse with surgical menopause, which is associated with an abrupt decrease in estrogen levels. Next slide, please. The risk factors for early menopause includes a family history. If you have a member of the family who also has early menopause, this increases your risk by 6 to 8 times, or even up to 12 times if multiple relatives are affected. If you have an identical twin sister with early menopause, then your risk of early menopause is increased 18 times. There are also reproductive factors such as being a twin or a triplet, or early onset of menstrual periods, especially before the age of 11 years, or very short and very regular menstrual periods can be associated with early menopause. Smoking is associated with a 2-fold increased risk of early menopause, and also being underweight. Lower education or occupation status has been shown in some studies to be associated with early menopause, and early life adverse events have been associated with an earlier age at natural menopause, that 50 to 51 years, but not specifically early menopause or POI at this stage. The diagnosis of early menopause is often delayed, as women or their doctors think that they are too young for menopause. Women who have not had a menstrual period for 4 to 6 months should see their doctor. There are a number of conditions that can cause menstrual periods to stop, and early menopause or POI could be one of them. A blood test to check hormone levels, follicle-stimulating hormone, and estrogen is used to diagnose early menopause or POI. But currently, there are no tests to reliably predict early menopause or POI at this stage. I will now hand over to Kirsty and Kate, who will talk about the experiences of women with early menopause. Thank you very much.
Thank you, Amanda. Hello, everyone. My name's Kirsty, And I have been living at the coalface of premature menopause. So first of all, I just wanted to thank Amanda for sharing that information and for the incredible work that she's been doing in this space. As she mentioned, there's still a lot that we could find out about, and it's really nice to be surrounded by incredible medical providers and medical professionals who are working in this space. Today I'm sharing my story for those in the audience who are currently experiencing premature menopause and for those who are supporting those important women. I just want to acknowledge that every woman's story is unique. My story is a little bit sad, but it has a happy ending. So when I was 31, my husband and I were able to conceive, and I was pregnant quite quickly. And unfortunately, we lost that pregnancy about 14 weeks. After we lost the pregnancy, my periods didn't return. And at the time, the health professionals who were looking after me thought maybe it was the stress and grief of going through that experience, which would be very understandable. Sure enough, though, they didn't return, and I started to get symptoms of hot flushes and other signs of premature menopause. So it was a 6-month exploration because no one really had the answers about what was happening with me, through lots and lots of blood tests and seeing incredible professionals like Amanda to kind of figure out what was going on. I have to say that probably the delivery of the news that I had premature menopause could have been done a little bit better, and that wasn't in any way a criticism of the amazing health providers at the time who were supporting me, but rather just a few things happened. Like, I wasn't expecting the news, so when I was told, the day I was told, it was a real shock to me. As well as that, I went and saw an IVF specialist with my partner, and that news was delivered by her after I had some ovarian reserve tests done as well. So you can imagine it was shocking, and it was also Christmas, and I was 31 and all my friends were having babies. On top of that, not only was I mourning the loss of the fertility, I heard all the risks that Amanda's just speaking about. So not only was I feeling grief, I was also feeling fear for what could happen to me in the future based on all of those risks. And there was little information at the time. We're talking 9 years ago now, I just turned 40, and there was little information at the time out there about what I could do. Many thanks to the Jean Hales Foundation, who had a really great fact sheet. Besides that, I felt like I was floating in space a bit, and I didn't know how I could empower myself to feel empowered to look after my own health, to reduce my risk, and also better understand what was happening at the time with my body. Unfortunately, on top of that, I have the BRCA2 gene, which is the breast cancer ovarian cancer gene, which meant that at the time I couldn't take HRT. So for 5 years, I sweated it out. And that was hard at age 31 because if I looked uncomfortable, I either might have looked embarrassed or I was, weird in my body. It was hard to explain to people what was happening to me at the time. And on top of that, I was only sleeping 4 to 5 hours a night. Besides the grief for fertility, loneliness was the hardest thing for me. The only people I could relate to were people my mother's age, and no one else that I knew was going through what I was going through. So it was a pretty lonely experience. And on top of that, I guess that's why I'm part of things like this, and I'm part of studies, and I'm part of things like HealthTalk Australia, because the more information we can get, the better. So what helped to get through this, I would call one of the hardest years of my life. Getting information was really important to me. So if you're someone who's like me right now, feel free to go out and get that information, be empowered about your own healthcare. Seeing a psychologist was really important to get that support, and finding a menopause clinic who could help me navigate through and understand my body better and find some good strategies. Also, I had a strong marriage, I had people I could confide in, and it was all about finding small joy in small moments. And finally, through some great research that's been done, I'm able to go on HRT, which has been personally for me a life changer, but is not always a viable option or a preferred option for all women. Also, what helped was not living my premature menopause story. And so over the last few years, I've been looking at different ways that I want to think about my identity. If I'm not going to be a mother, then there was other ways that I could think about being part of the village, being an auntie, being a godmother, and also being a strong woman who loves to hike and ride bikes and swim with a nice, strong, healthy body. So I guess 9 years ago, I was experiencing incredible hardship and pain, and I'm 9 years later saying that things have got easier, they've got better, and I've had lots of gifts from this experience. I've learnt that it's okay to be part of the village and not have your own children, and there's lots of ways to live your life. I've learnt about how I can create strong bones, and it's not just about having a bikini body. And I have learnt how to look after myself better. I take downtime when I need it, and I've learnt that it's all about seeking joy in life and seeking purpose in life. So if you are currently in the midst of this early menopause or premature menopause journey, I just want to say to you that you've got this, you're not alone, and there will be good things that come from what can feel like a really challenging experience. So that's my story, and I'm here to answer more questions if you want to ask them. It's my honour to pass over to Kate Johnston-Ataata, and she's going to tell you a little bit more about premature menopause. Thanks, Kate.
Thanks, Kirsty. So I, as Rhonda introduced me at the beginning, I'm a sociologist, health and family sociologist at RMIT, and I collaborated with Amanda and Jackie on the Experiences of Early Menopause project, for which we interviewed Kirsty, so that's how we got to know her. So I'm just going to speak a little bit about the study and some of the findings, focusing on the personal and social impacts of early menopause in women. So the project was a collaboration between clinician researchers at Monash and social scientists at RMIT. We knew that, as Kirsty said, women with early menopause often felt alone and isolated, and that online information wasn't always easy to come by. So our goal was to create an online resource that put women's experiences at the centre, but was also accompanied by up-to-date, credible health information and other practical resources. So, for example, fact sheets, a question prompt list, and a national list of health services available to help women with early menopause. So to achieve this, we interviewed 30 women with both spontaneous and medically induced early menopause. And we did very broad-ranging interviews with them. So we looked at not only their health and medical journeys, but also their personal and social aspects of the condition. And women could decide to be video or audio recorded, and we used then those recordings to create the online resource that you can see the link to on this slide on the HealthTalk Australia website. So next slide, please, and I'll tell you a bit about who we spoke with. So about half the participants were women with early menopause that was related to cancer treatment, and they'll be the focus of the next 2 webinars in this series. So today I'm just going to be talking about the other 15 women. So 11 of those had spontaneous early menopause and 4 had medically induced early menopause that was related to treatment for benign conditions, so for things like endometriosis and ovarian cysts. Their average age at diagnosis was 37, and they were from a range of backgrounds. Most were born in Australia, but some were born overseas. And most lived in the city, but we had about 5 that lived in regional areas. 13 women were working and a couple were on leave or volunteering. They were fairly highly educated, ranging from diplomas through to PhDs. 10 women were partnered and 5 were single. And about half of them had children and half didn't. And there was 1 woman whose same-sex partner was expecting a baby at the time of their interview. So next slide, please. Moving to the findings. So here, these sort of dot points capture, a huge range of issues, obviously. And if you're interested in reading more about this, you can go to the website and you can see sort of all of the stories about this. But clearly, fertility loss was a very big issue for many of the women that we spoke to. And it was particularly difficult for women who hadn't yet started their families, which often forced them to kind of rethink their life goals and plans. But it was also hard for women who already had children but had hoped to have more. And women who hadn't ever wanted children obviously found it a little easier to accept, as had women who already completed their families. Although there was the observation from a few women we spoke to that fertility is not just about childbearing ability, it's also about your overall health. Social expectations around fertility could also be very hard to navigate. When women are in their 20s and 30s, it's something they're often asked about by all kinds of people, and that could lead to some quite uncomfortable conversations, particularly when people disclose that they had early menopause and the reactions they got. Only 1 of our participants had gone through IVF, and none of them had pursued adoption or fostering, though they shared their thoughts and feelings about those options. They also reflected, as Kirsty said, on other ways to have children, or to be involved rather in the lives of children, including through friends and family. Body image and women's sense of sort of feminine identity were very significant issues. As for many people, fertility was actually tied up with their feelings of attractiveness and youthfulness. And as we know, we often associate menopause with the idea of ageing. As Kirsty also alluded to, early menopause could be quite a lonely experience, particularly as very few of our participants knew of anyone else with the diagnosis. Because women spoke about the kind of difficulty of, on one hand relating to their peers who were often starting families, and at the same time they couldn't relate either to women who had gone through menopause at the usual age because it was an expected life experience for them. They also talked about the impact of early menopause on their relationships with a variety of people in their lives, from partners through to parents, children, friends, other family members. And they both often spoke about the fact that people who are open to the experience and not judgmental, those were the relationships that really supported them and that thrived through this. Early menopause is obviously quite challenging in terms of intimacy and dating, both because of the physical effects of early menopause, but also those kind of issues around identity, loss of libido, etc. And women were kind of in a range of situations, from sort of dating through to new relationships and more established ones. And finally, women spoke about the impact of early menopause on work. So often the impact of symptoms on work or study, and the levels of support or sometimes lack of support they experience from employers, and the impacts on their longer term career paths. So that's just a little sense of some of the things that we heard from the women that we spoke with. And as I said, you can visit the website for more details. I'd now like to hand over to Associate Professor Jackie Boyle. Thank you.
Hello. So I'm going to be speaking about managing early menopause. And I think it's really important, as Kirsty referred to optimise your health and work on being healthy. So, and try not to focus on it as an illness per se. Next slide, please. So it does require a holistic approach. Certainly a healthy lifestyle is really important for a number of reasons. So as we heard Amanda talk about the increased risk of cardiovascular disease and also bone fragility, it's really, healthy lifestyle obviously is really important for that, as well as for women's mental health. So being physically active, having a balanced diet with enough calcium and vitamin D, stopping smoking if you're a smoker is also important, and minimising alcohol use. Hormone replacement therapy can be, if it's not contraindicated for other health reasons, is recommended to relieve symptoms, and it also reduces the risk of bone fragility and heart disease, and it should be continued until the usual age of menopause. And if used in that way, it's important to remember that it's really just like replacing what you would have been, the hormones you would have been replacing normally if you hadn't had early menopause. It's also important to screen for other health issues. So usually we would do a bone density scan, and then you may have those repeated over time. And that's to monitor how the bone density is progressing. It's also important to have your blood pressure checked regularly and to try and maintain a healthy weight. And we would also do blood tests to look for your risk of heart disease. So that would include things such as your cholesterol levels. Next slide, please. It's really important to remember that hormone replacement is not a contraceptive, and there is a small risk, about a 1 to 5% chance in over a lifetime of women with premature ovarian insufficiency becoming pregnant. That's most common in the first couple of years after diagnosis, but it is important that if you really don't want to become pregnant, then you talk to your doctor about using contraception. As has been mentioned earlier, infertility is obviously, it can be quite devastating for women. It can be managed differently depending on what the cause is. So for example, there's a lot of women who with spontaneous early menopause, such as Kirsty, who have no warning. So it's very difficult to do anything about that. For some women, however, for example, if they're having a medical procedure or treatment for cancer, they can consider having ovarian suppression or having eggs collected before they start treatment. Some women may also choose to adopt or to be childless. It's really important to remember that if you've had any anxiety or depression or other mental illness, sometimes that can be exacerbated in that transition with premature ovarian insufficiency, in addition to obviously the distress that it can cause from the nature of those things such as infertility and change in how women are feeling about themselves. So it's really important to seek support and to have counselling and treatment if required. Next slide, please. The other thing that I think is also really important that often is not mentioned is, and that women often find difficult to talk about and doctors often don't raise, is psychosexual health and, you know, difficulty either having sex because it's painful or change in libido and how women are feeling about themselves, and that's really important to seek help for as well. In terms of other things that we can use to manage some of the symptoms of menopause, particularly for women who can't use hormone treatment, cognitive behavioural therapy has been shown to help hot flushes, sleep and mood in postmenopausal women, and hypnosis has also been shown to help hot flushes. There are also a number of non-hormonal medications that are available for women who can't take hormone replacement therapy that can help with hot flushes and vaginal symptoms. We don't usually recommend complementary medicines because the evidence around their benefits are unclear. So they're either ineffective or there are some concerns about safety. So at the moment we don't recommend those. So I think that's a quick snapshot, and we'll go now to the panel. So if everyone would like to join.
Okay, so thank you all very much for being very tight with your timing there, because we want to get to the exciting part, which is now answering your questions. So as I said, we'll start with the questions that were pre-submitted, and I'll direct the first question, if I can, to Amanda. So Amanda, this question is, what age is considered early?
So as I said in my presentation, Rhonda, any age before 45. So the average age of menopause, of natural menopause, is 50 to 51, and that's pretty consistent across the world. But if your menopause or your ovaries stop working before the age of 45, that's considered early menopause. And then before the age of 40, that's when it's considered premature. And that usually affects anywhere between sort of that 1 to 3.5% of women. They're under the age of about 30, that's 1 in 1,000 women may experience that very early age of menopause, which is around the time that Kirsty was experiencing her loss of ovarian function.
Okay, thank you very much. So I might direct the next one at you, Jackie. There's a question here around if there's anything that can be done to delay it. So if women are starting to experience symptoms of early menopause, is there anything that can slow it down?
No, unfortunately there isn't. As I said, sometimes if women are undergoing treatment for some cancers and things, they can do ovarian suppression, but in terms of if you're starting to get symptoms of early menopause, unfortunately, there's nothing that we can do to actually slow it down or stop it from happening.
Okay, it's pretty clear. So the next question is around, there's some of the other symptoms surrounding early menopause. Jackie, I might direct it back at you, or if any of the other panellists would like to speak as well. Kirsty, if you'd like to speak on this as well. So it's the questions around incontinence, brain fog, and also the questions around estrogen levels and what's happening around estrogen levels and how that might impact women. So I might direct it first to you, Jackie, and then if the other panellists would like to jump in.
So in terms of brain fog, I think as Amanda said earlier, the evidence around menopause actually affecting cognition itself is not so clear, but certainly we know that particularly poor sleep can certainly impact your day-to-day functioning and feeling a bit foggy. Many of us are feeling a bit COVID brain foggy at the moment as well. So certainly by working on sleep, and sleep can be impacted. Sometimes it's a bit difficult to work out what's actually causing it. Sometimes it can be the anxiety and distress. Sometimes it can be the hot flushes that are waking you up. So it's trying to work through and maximising your sleep can certainly help. I think also you mentioned about the urinary symptoms. Certainly dry vagina and those genital symptoms with the loss of estrogen can impact on how all of that area feels. So you can have dry vagina, sex can be painful, and women can have some urinary symptoms. And certainly sometimes using localised vaginal estrogen can help with those symptoms. What else did you ask? Was that it?
Yeah, so I think you've covered it pretty well, actually.
I might just jump in there, Rhonda. So it looks like there are estrogen receptors in the brain, so estrogen is important in sort of brain function in women. And they've done some studies which suggest that particularly verbal fluency and verbal memory is affected by lack of estrogen, and that can be improved by giving HRT. There is the data around other aspects of cognition and dementia was mainly done in those women having a surgical menopause, and a lot of the studies are quite old now and weren't the methods that they used to assess function was maybe not so robust. So I think that this is still an area of active research, and we need to learn more. I mean, the other aspect is always, why the woman might have gone into developed POI, because if she's had chemotherapy, certainly chemo brain is another thing that could impact as well as potentially POI.
Okay, and we might go into more detail in the next webinar around that. I'm just wondering, Kirsty, if you had any thoughts around, the issues around brain fog and your experiences around some of those things that we just chatted about.
Thanks for asking, Rhonda. It's funny, listening to everyone talk about this. It's like living it is no fun. I guess for me, some things besides being really kind to yourself and being gentle is really important. I found sleep hygiene was really important. So not just getting the right amount of sleep, but working out where you're going to do that. So I definitely woke up many times during the night. I figured out, even though it was a bit of a splash of cash for my husband, that sleeping in a king size bed meant that I just had a little bit of, area to myself where I could be hot and throw covers on and off and not disturb him and not, wake anyone else up. Also, going to bed at the same time every night. I found having a bath and calming you down helps. So I treated myself a bit like ironically, because I couldn't have babies and just found that out. I had to treat myself like a baby and set myself up a bedtime routine just like we do with children. And I found that helped. But I had to be accepting because of lack of sleep that I hardly could go out for dinner because I didn't feel safe driving home at night. So I think also it's about trying to find ways to still find joy and just navigate your way a little bit through the process of it. So, like having people drive me home so I could go out for dinner and not getting so hardcore and taking it so seriously, because it does overwhelm. The other thing was that mindfulness became really important to me. So learning how to, when I wake up in the night, to calm myself down, because I naturally already had anxiety as a disposition because of my family's genetics. So being able to not feel so frustrated and angry when I woke up, because as soon as that activated, then I was awake. So, and all of that definitely led to brain fog. But clearly I don't have an issue with verbal fluency, so that's good to hear. So I think it's about finding out what works for you. And for me, it was mostly about trying to stay cool. So like, I used to even ask before I went to a meeting, and I'm an educator, right? So I spent a lot of time speaking at conferences and running and facilitating workshops. I had to find out whether there was air conditioning there. So just simple things like that, building a bit of a toolkits really helps with that stuff.
Great, thank you very much. And since we're in the bedroom, we might stay there. And Kirsty, I might go straight back to you. Yeah. Just to kick off around how it impacted your libido, how it affected your relationship, your sexual relationships, and just anything you might want to add around that.
Thanks, Rhonda. Look, I just want to also acknowledge, watching the Q&A, that there are women in the audience who are in it with me, and I just want to say you're not alone. We're in it together, and together we're stronger. So thank you for being here. For me, it definitely affected my libido. I also came off the back of having to finish a pregnancy, so already things were not feeling amazing in my body. I found personally, besides vaginal dryness, and isn't that a great thing that you get to add to your lingo at 31, I felt weird in my body. Like I did, through my grief and not sleeping, stack on quite a lot of weight. So my body felt like it changed. Also, listening to the risks, which I got from my specialist, all of a sudden my body felt old as well. I felt old in my being. And so that definitely affected how I felt sexually, because I felt like an old woman trapped in a young woman's body who was hot and things were not working properly. So some things that helped were really for me around body image. It was about reframing the way I felt about my body, about finding clothes that made me feel confident, that made me feel good about my body, even if that meant hitting up the op shop if budget's limited. It was about finding some ways to be able to express who I am. It turned out I really got into clothes and bright clothes. So I found ways to feel young. I actually stopped wearing some of my clothes because I felt like I was about 20 years older than I was. And all of that then led to a better libido because I realized a lot of it was psychological. Also, I think I had to be like really clear with my partner and really honest with my partner. And there's nothing more than a mood killer than that. So having a pre-chat before you get in the mood was really useful as well, just so that you didn't have to say things in the moment. So yeah, I figured out some tools, but also I think I was gentle on myself for the fact that things were changing as well. I guess personal kindness is generally the theme here for me.
Yeah. It's a fantastic message. So I might put that same question to Amanda, just talking around sexual health and how some of the treatments that might be available around to assist.
So we know that, so as Jackie sort of commented before, we know that estrogen is really important for urogenital, like vaginal health, okay? So there are estrogen preparations which can be delivered into the vagina. They're usually creams or little pessaries. And so they replace the estrogen back into the vagina, which helps that vaginal dryness. And it also can help if there's any urinary incontinence, urinary leakage as well. The particularly good thing about that is that women are always worried about the risks of HRT, although women with POI are a totally different group compared to the women over 50 which all the WHI studies were about. We do know that the vaginal estrogen is not absorbed into the system, so really it stays locally in that vagina, so it's very safe. If those women, there are non-vaginal moisturizers as well that can be used. I think as Kirsty was talking about, there are multiple impacts on a woman's sexual functioning and well-being. You know, it's not just the vaginal dryness that might be associated with low estrogen. It's, you know, as Kirsty said, it's about your feelings about your body image, you know, feeling old before your time, that whole psychological impact, your self-confidence. If your POI is in relation to cancer treatments, it's the actual impact of the cancer therapy on the vagina and on your general well-being with cancer-related fatigue. The question about testosterone therapy, that can be helpful to some women. But again, with all of these things, that needs a discussion with someone who is used and can talk through the risks and benefits of testosterone. It's not a magic cure-all for low libido, but it can help in some women. And obviously the relationship with your partner and, you know, what's going on in your life. If you have a really stressful, busy life, then often anyone's libido may be decreased in that sort of setting. So I think it's really important to remember that it's multifactorial. There are a variety of things that can help.
Thanks.
Rhonda, can I jump in?
Yeah.
I just wanted to say that as a gynecologist, I often see women who've had problems for ages in their, relationships and in their sex lives, and they often haven't told anyone. So I would just really like to reiterate that it's really important to discuss it with someone, and if you can't discuss it with your regular GP, find another GP or someone to talk about it with, because the problem is that if you leave things go for longer, it's harder to then fix. And also it may not even be due, to menopause. Certainly some of the physical symptoms that can occur with pain having sex, or even a dry vagina and problems with skin on the around that sort of outside area around the vagina, can actually be due to other things. So it's always really important to talk about it and to get checked out. And you're certainly not alone. It's one of the most common things that that I see with women. And there are certainly really fabulous sexual and medical therapists out there that are really great at working with couples or with women. So yeah, I would just encourage women to get help.
Yeah, thanks, Jackie. And again, just a reminder that there's a link in the chat around how to find some of the practitioners that Jackie's talking about. So Jackie, whilst you're got your microphone on, I'm going to direct this next question at you, which is around what research has been done for early menopause in Aboriginal women that you would know about, given your experience working in this field.
There's not a lot, actually. There's been a couple of small studies, but there actually hasn't been a lot in Australia. There's been some overseas, particularly in Canada, with First Nations women, and certainly generally there have been some differences in terms of how women and society can perceive menopause. So in some of those cultures, once a woman reaches menopause, she's considered to be, a respected elder. So, for some of those women, that's more of a positive. There certainly is concern, I think, in terms of some of those other risks, such as cardiovascular risks and things, where some First Nations women already have an increased risk, and having early menopause could potentially exacerbate that. But yeah, there's very limited research in Australian Aboriginal women.
Okay, thank you very much. Now, my next question, and I just, anyone can jump in on this one, is around, is there a relationship, an established relationship between trauma and early menopause? Any research anyone knows?
So there has been, so this is looking at how they do these studies is they look at large groups of women, and they look at what their age of menopause is, and then they look at a whole lot of what their experiences might have been. And certainly the evidence suggests that adverse early life experiences is associated with an earlier age at menopause. So not necessarily early menopause, but maybe instead of going through menopause at 50, 51, maybe it shifts it back to sort of 47 or so, although that's sort of less clear. And when I say adverse early life experience, that means poor parenting, if parents divorced before the age of 5 years, if there was undernutrition or neglect of the child. There is some evidence for sexual abuse of children. So that can be associated. As far as trauma is in later life, there's no evidence that intimate partner violence in the adult is associated with early menopause. We do know that lower socioeconomic sort of status, so lower education, lower occupation can be associated with early menopause POI, but that's probably related to a number of different sort of impacts, lifestyle, environment, possibly genetic, impacting on that.
Okay, so it's a little bit vague. I'm hearing it's vague right now. Okay.
Yeah, definitely, maybe, but no definite evidence.
Terrific. All right. So Amanda, can I direct this one at you? So other than chemical or surgical early menopause, are there known causes or indications for who might be more vulnerable? And I think you might have just touched on that a little bit, but is there anything you want to add to that?
Probably nothing that I added to in the from the slides that I said before. I think the main thing is to perhaps determine if you do have any of those risks, and think about it's really often to think about your fertility plans, really, because unfortunately at this stage we can't predict who's going to develop early menopause, and we can't prevent it, as Jackie said. So if I was someone whose mother or had aunts or sister went through an early menopause, well, I'd actually want to seek some fertility advice earlier on, or think about having my children or freezing eggs or something like that at an earlier age, because my risk is potentially increased for an early menopause.
Okay, terrific. Thank you. So Jackie, if I can direct this next one to you, and it's about long-term risks. So are the women that go through early menopause more likely to suffer other health problems than their peers?
I think, as we talked about earlier, there is an increased risk in cardiovascular disease, so heart disease and stroke. So that's why we monitor blood pressure and do blood tests to assess risks for heart disease, as well as doing those DEXA scans to monitor bone density. And that's why it's really important to, look after yourself and stay as healthy as you can. And as Kirsty said, doing that within, looking at your overall life and trying to be happy and looking at it holistically. Yeah.
I can chime in there as well. As a patient, it's really hard to hear that you have premature menopause, and then often in the same breath it's delivered all of the risk, and we know that that's good competency for our medical professionals. So for medical professionals who are listening in, I know that you would do this, but I just want to say that this information needs to be given gently, and it needs to be given with some solutions. And I know that you would do that, but I think it's important to know. And as a patient, if you're hearing that and you're not getting what you need, it's also okay to ask your incredible medical professional, like the women we have here today, to say, can you tell me more about that? Or how might I, if this is now an issue, what are your recommendations here? And if you're still feeling fear like I did around the future, then find someone to talk to about it. For me, obviously, I'm not going to say psychology is for everyone, but having someone who can help you process your fears and step in more confidently into your future really helps. In fact, I'm not the clinical person here, so I can be a rebel and say things that maybe other people in the room can't say, but I would say that every woman who gets diagnosed with premature menopause should be given some sort of support group or some sort of psychological support where needed, because it's tough to hear those high risks on top of the news. So I'd say the people who every time Jacqueline or Amanda or Kate might be talking right now about risk and getting heart palpitations, I just want to acknowledge that might be happening in the room, and I feel you on that. And I just want to let you know you're not alone if you're feeling weird about that, and also that you can step more confidently into your future around that as well.
Yeah, such important points.
Yeah, thanks, Kirsty.
Thank you so much.
That's great, Kirsty. Can I just add, I think that one of the things that is reassuring is that using HRT, as long as you have no contraindications, actually helps to minimise those risks. So it not only can help with the hot flush with the symptoms, but it actually does help to decrease your risk of heart disease. It helps to decrease that risk of osteoporosis. So I think it's really important that you do all the lifestyle, pay attention to your lifestyle, the exercise, diet, etc. But also, Kirsty was talking about tools. I think that HRT is in your toolbox along with your diet and your exercise, and is helpful.
And it is
Yeah,
also
Amanda.
a matter of managing your personal risk because, you know, for example, some women will require, say, additional medication and things to manage cholesterol and things, but it's very much, you know, getting that individual assessment and working on that with your doctor as well.
That's so true, Jackie. You know, that knowledge is power is so important here. I went through a stage where I was like in full avoidance. I didn't want to get my bone density scan. I definitely didn't want to get my cholesterol checked. I was worried about what I would find out. But once I did that, oh my gosh, so much relief. And also knowing that I could sleep better at night, knowing that I knew where things were at. So yeah, highly recommended.
Yeah, great. Yeah, good point. And Amanda, a really good point around the use of HRT. We, you know, many of us are very fearful of using HRT, but in this instance, we know that there are many benefits in the right context for the right person. So it's good for women to know, to be asking questions about that and whether it's an appropriate medication for them at that time. So we're getting close. We're moving along very nicely here. I want to ask a really important question here of Jackie. Jackie, can we talk about fertility? Can we talk about the chances of women getting pregnant who have been diagnosed with early menopause or POI?
Yeah, so as we mentioned earlier, it does depend on what the cause is. If you've had premature ovarian insufficiency then you can still, as we talked about earlier, get pregnant. The chance is low, and it is most likely in the first couple of years, but it can happen. So if that's not what you want, you need to think about contraception. And apart from that, also, as we said, if it, you know, as Amanda said, if you know that there's a family history or if there's other risk factors, then it's always good to either think about having your family early or seeing a fertility specialist to discuss your options. Unfortunately, you know, and if you're going to have treatment for cancer that you know can affect it, you can have drugs that shut your ovaries down and may be protective possibly. But also you can also discuss before you have treatment either freezing your eggs or freezing embryos, depending on what your situation is. You know, unfortunately, none of those are completely, will completely guarantee that you will be able to have a baby, but it is really important, again, that you have those conversations, that you know that there are those options available, so you can take them up if they appear to be the right thing for you.
And Jackie, if egg donation becomes, pertinent for someone, where's the best place for women to find information around that?
So there's a lot of really good information on most of this on the Victorian Assisted Reproductive Treatment Authority website, as well as all of the fertility clinics. They all can give you information on egg freezing, embryo freezing, egg donation, surrogacy, all of those options you can talk about with them and find information on.
Terrific. All right. So my next question I'd like to direct to Kate, and Kirsty, you might like to chip in here as well. And just talking about and we have touched on it, but just talking about some of the psychological distress, I'm going to go there, and support needs. So Kate, in your interviewing, what can you tell us about the psychological impact that the women were telling you about?
Yeah, I think that, as I noted before, it was often a lot of distress around loss of fertility and also, these long-term health risks that Kirsty has spoken about, that fear and the shock. And I think a lot of women spoke about the fact that they just hadn't even heard of early menopause themselves before they were diagnosed. So it was sort of not only the shock of the diagnosis, but just something they never even knew was a possibility. So I think that in that sense, much more community education about the condition in general would be great. And I think too, if you're supporting someone who's got this diagnosis, just to be very understanding. And I think women also need to really stop asking one another, or men as well, sometimes insensitively about, having children and things like that. It's just a private question and you have no idea why a person doesn't have children. Did you want to add to that, Kirsty?
I'm enthusiastically head nodding to what you're saying, Kate.
Yes.
I was actually quite shocked when I told people that I had premature menopause. Even a new GP asked me whether I was sure. And while I understand the reasons why people might ask that, because as it's not spoken about in our society, when I told them that 1 in 100 women were experiencing it, then yes, I was sure. I'd been to, 6 months of a medical journey to figure that out. Yes, and the stigma around it, and people asking me, well, have you tried adoption? Have you tried, like, the 50 million questions you get asked about? You're like, oh no, I'd never thought about adoption. Thanks for that great suggestion, she says sarcastically. But I think that it's amazing. So I started speaking out about my situation on social media, on Facebook mainly, amongst people that I knew in a safe space. And they always tell me thank you, because I don't know about this. So I would love for this to be something. I mean, I actually think beyond premature menopause is not spoken about very much in society, except for maybe in special women's circles when women are getting together for coffee. I would like to see menopause as a whole become more of the conversation we can have as a society, to remove some of the stigma around it, and to help people feel empowered in that space. That would be amazing. Would have been amazing for me if it had already been out in society. But in the 9 years that I've been experiencing premature menopause, there's been some significant things that have happened. First of all, I'm no longer called a ovarian failure. And I know that that for me, psychologically, has actually been a really important thing, this change in the name, for whatever reason was decided. Be told that your ovaries have failed in the language is hard to hear. Apparently there was a character on Neighbours who had premature menopause. And quite a few people reached out to me to say, oh my gosh, you're now on television. So that was great to hear as well. So the more
Kirsty, I'm going to tell you a story. We actually supplied the materials for that episode on Neighbours.
Well, Rhonda, we can kiss your feet. Thank you. That's fantastic and really grateful.
I have done something good.
Yeah,
so
I think
I'm going to
things like that.
I'm going to just finish up there, Kirsty, because that's a really good thing to finish up on. And thank you so much for that. That message, the call to talk more about menopause, talk more about early menopause, talk more about all of these things. And Kirsty, you're a tremendous advocate for women experiencing this. So I'm going to start to wind up. I'm going to thank Kirsty so much for, the heart that you always bring into your story, and I always enjoyed listening to you. And I thank Jackie and Amanda and Kate for your, not just your knowledge and your experience in this, but the passion you bring to it. And it's a great privilege for me to work with you, and I always feel very honoured to be discussing this with you. So I thank you all very much. And I also want to thank our partners in closing. You can see we have numerous partners from the screens behind the speakers there. I want to sincerely thank Women's Health Victoria and Renata in particular, who's running the technology behind the scenes so seamlessly here. We're very grateful to her. We know that you'll be looking for more information, which is why we have put some links into the chat, but also we have recorded this session, as I said earlier. So in a couple of weeks, this will be on Women's Health Victoria website with those links that we've discussed for you to find further information. So I thank you for your time. It's been a tremendous honour for us to be with you today. Don't forget, we have 2 more seminars coming up, and we look forward perhaps to seeing to some of you there, or to telling people that you think may be interested. So we'll wind up there, and I just want to say thank you to everyone involved.